Precision medicine in asthma is, I think, a very important advance in the concept of how we are approaching our patient. And it means that we have always to go for the personalized, for the predictive medicine, for the preventive medicine, and also for medicine driven by specific phenotypes of the patient. So there has been a whole move in asthma really looking at phenotypes and the underlying biological mechanism, because one patient with asthma and another can be very different in their clinical expression, also in their physiological expression when you measure lung function, and also when you look at airway inflammation there can be important difference. And the clinicians should be aware of that because the treatment is not the same in every patient. I'm convinced that that will be cost effective because the principle is that it should be personalized. So you really have to look at your patient. An example is patients who have difficult to control asthma. They are considered to be severe and difficult to treat in practice, and it's about 1 in 5 patients who are not easy to treat with the classical inhaled steroids or the combination ICS and long-acting bronchodilator. And the first thing that we have to think about when we have a patient that is not responding to the regular and more cheap therapy, why is it? Is my diagnosis correct? Has the patient asthma? Have I confirmed it? And then the second important question is, does my patient take the medication? Well, we know that more than half of the asthmatics don't take their medication chronically. So you cannot expect from a drug working when you are not taking it. So this is a very important personalized approach, really looking whether my patient is taking it. And the other point is, the third point, does my patient take the medication in a correct way? Because we have the inhalers, and this inhaler technique is not always that simple for patients, so they are taking the medication but in the wrong way. So this is already a personalized approach. When your patient then has got it checked, it is asthma, he or she is taking the medication, and he or she is taking the medication in the exact way, in a good way, then we have to think about other things. Are there comorbidities? For instance, is there allergic rhinitis, chronic rhinosinusitis, or is my patient still smoking or being exposed to the smoke of somebody else? Is there air pollution? So environmental factors. Comorbidities like allergic rhinitis, but also obesity, sleep apnea syndrome and others. So you have a personalized approach there. And then last but not least, I should say, patients who are still having severe asthma with exacerbations, who are even being hospitalized for asthma, this is then the real severe asthma patients. There we now have new biological treatments, which are expensive, but only used in a very good selected population. And I think this is clue. If we want to control the cost of this, it really needs to be in the exact patient and targeted towards IgE, towards IL-5 or something else.